couple of additional things I'd like to point out as far as this slide goes. When we're talking about weight gain of the infant, what we really want to remember is that during that initial newborn period in the hospital, it's going to be very typical for the infant to lose 5 to 6% of their birth weight, and then they'll do a discharge weight and then follow that once they're discharged. So if the infant weight loss is greater than 7%, probably what you'll be seeing is maybe physicians watching them a little closer, having them come back to be reweighed. What we'd like to see is infants gaining 110 to 200 grams per week or 20 to 28 grams per day. Along with engorgement, I did touch a little bit about wet and dirty diapers, and truly what we should be seeing for wet and dirty diapers is about 5 to 10 bowel movements in the beginning stages, and then we'll see that to change to about 1 every 3 days. A lot of it is going to be dependent on if they're bottle or breastfed. And then with wet diapers, what we'd like to see with wet diapers is 6 to 8 wet diapers per day. When we talk about engorgement, engorgement we talked earlier, but it is due to the sudden changes in hormones and will resolve with time. And like I said, breastfeeding is on a demand basis, so it's going to be supply and demand. And there will be times that the woman feels like she's breastfeeding much more frequently, and it's just due to growth spurts that the infant is going through. If mom has sore nipples, she does need that needs to be addressed. It's going to be okay to have sore nipples for about the first week of breastfeeding, but then we want to see that taper off and get better. The use of lanolin cream is good. Chilled cabbage leaves 2 to 3 times a day. Warm showers, massage. If her nipples become severely cracked or bleeding, that stuff is not okay, so she does need to be referred to a lactation consultant or a breastfeeding educator, because really when you get right down to it with breastfeeding, the key to successful breastfeeding is really education and guidance. So utilizing the lactation consultant's assessment of the mother's breasts and nipples during that last trimester of pregnancy. So that really falls on the role of the physician, because if she has flat or inverted nipples, we need to be getting her a breast shield to utilize to help release some of those adhesions, and you just wear them in the bra and it helps pull the nipple out. So we can get those things started earlier. It's good to talk to the patient if she's had breast surgery, so maybe breast reductions or breast enhancement, because if with reductions we do see a decreased amount of breast milk produced. It's not that she won't be able to produce enough, but the amount can be decreased. Also, remember the importance of breast milk when you're providing education, that it has, it's specific for the species, it's full of IgA, it does have a laxative effect, so we see decreased constipation. So lots of really great benefits as far as breastfeeding goes. With formula feeding, things that we need to educate moms on, signs of readiness of feeding. So that's really similar to breastfeeding infants. Is the baby, do they have the Moro or the rooting reflex? Are their vital signs stable? Do they have the sucking reflex? Those kinds of things. With feeding patterns compared to breastfed infants, I did kind of address that earlier. So just remember that formula feeding infants will probably, feedings will be spaced out a little bit further between each feeding session. There are many different bottles and many different nipple variations. The thing to remember when providing education is to wash them with warm soapy water and boil them for about 5 minutes prior to the first use. After the first use, it's okay to just wash with hot soapy water, or sometimes they're dishwasher safe, but we want to just make sure that we get them clean so that the baby doesn't end up getting thrush or a yeast infection in their mouth. With formula preparation, there are different varieties. There's ready to feed formula, there's liquid formula that you have to dilute, and there's powder formula. So when you're thinking about education, the thing with that is the ready to feed is the most expensive, but it is the easiest to use. It's okay to be refrigerated for up to about 48 hours after its opening. The thing to remember with ready feeding is that we need to wash the top of that before we puncture that and open it so that we're not putting pathogens inside. With powder, it's typically 1 scoop of powder per 60 ml of water. It's very good for travel. You can mix it as needed. If you are going to, if you're where there is dirty water or on clean water, we want to encourage parents to boil that, allow it to cool, and then it's going to be okay for use. So burping, typically about every ounce to 2 ounces, we're going to burp the baby. It's important to educate on no propping of the bottles. We let the baby hold the bottle when it's old enough. But we still want the baby to be held. In the newborn and early stages, the baby needs head support. So we want to encourage no propping of bottles to help encourage bonding, ensure that the nipple is full of formula, and then also burping once we are done. Nursing interventions, so just different things to assess for. So we do want to make sure that parents do have adequate understanding of how to prepare formula. And unfortunately, there are parents out there that do not, so don't hesitate to ask and offer instructions so that they have a good understanding before they are discharged. Make sure they understand about how to prepare the bottles, burping, and then being aware of thrush. So developing a discharge plan to address the needs of our family upon discharge. These are just things listed out that our patients need to know about prior to discharge. Really, temperature greater than 100.4 or any sign or symptom of infection. It's important that they know to feed the baby on demand, bond with the baby, comforting measures, so swaddling techniques, holding techniques, determining needs on what the baby is doing. So if the baby's crying, it's not always because the baby's hungry. It could be that the baby's wet, maybe that the baby has a tummy ache. So just lots of different things. And then we do want mom to recognize that she does need to get some rest during this postpartum period. So it's best to tell her that when her baby is resting, that's probably when she should rest as well. These terms listed out up here as far as the taking in, taking hold, and letting go phase, you do need to be very familiar with them. So I would pause your video and take out a highlighter and make sure that you have this slide highlighted. When we're talking about the taking in phase, that's where the mother focuses on herself. So with the taking in phase, it's really usually right after delivery, and she's more concerned with taking care of herself, making sure that her needs are met. And then once her needs are met, she will start to then go into the taking hold phase, where she focuses on competent mothering and baby care. So during that taking hold phase, the mother really feels like she's the only one that can feed the baby, the only one to burp the baby. If the baby's crying, she wants the baby back. So we want to see in that taking in phase the engagement, which involves making the commitment to become a mother and caring for the baby. We want her to experience herself as a mother. What are her experiences? How has she adapted to this? How will she adapt her relationships? A woman can see childbirth as a sense of loss because they're not pregnant anymore, and so it can cause some anxiety. So we do want to encourage coping mechanisms, and then have her eventually move into that letting go phase, where she starts to function as a family unit, where we allow dad or significant other or grandparents, everyone to help out with the newborn cares. As far as transitioning into home, typically what we do see is that the home health nurse will usually make a home visit, typically a day or two after mom is discharged from the hospital. We want to encourage her to call OB if she has any questions or concerns. Let her know information about local support groups, especially if you have a breastfeeding mom. It's good to let her know about the La Leche Leagues, and then referral to other community sources. So if she needs best care for better babies, Title 19, WIC, all those types of things, it's important to remind her to ask for help when it's needed, so she doesn't become exhausted and then sleep when the baby sleeps. If she has to limit visitors, a really good way to limit visitors is to put a sign on the door of her home that says she and the baby are sleeping, please come back later. Unplugging phones, turning them off, putting them on silent, anything so that it will promote her to have some rest. So causes and symptoms of some of the puerperal infections. Any infection of the genital tract that occurs within 28 days after miscarriage, induced abortion, or childbirth. Because remember that we said that this time is 4 to 6 weeks after delivery. And these infections really are a major cause of maternal morbidity and mortality worldwide. And when you go back and you look at Healthy People 2020, you will see that one of the major goals is to decrease the incidence of maternal morbidity and mortality when we are looking at normal, healthy women having babies. Box 23.3 does talk about some predisposing factors for these infections. So we'll take a little bit of time to talk about endometritis, wound infections, UTIs. We have visited about mastitis. With UTIs, we see them being common in women that maybe have had the epidural and are having difficulty urinating, and we have to do in and out catheters. We can see urinary retention with the use of pain medications, narcotics, especially those epidurals. So making sure that we're using aseptic technique. With wound infections, keeping them clean, warm, dry, looking at those. Those are all going to be very important parts of our job. Things that we need to do, prevention is key. So going back to that primary prevention, administering antibiotics, hydration, rest, and pain relief, watching her lochia. We talked about how that lochia needs to change and become less, provide comfort measures, and just to keep her comfortable. So we did talk about mastitis earlier, and we did talk about having some red streaking. This obviously is breast tissue that has a great deal of infection in it. Typically, mom's going to be able to continue to breastfeed, but it is going to be somewhat uncomfortable for her. We see increased risk of mastitis when there are small cracks in the nipples, or if the breast tissue gets open for any reason. And so we do want to educate on mastitis, so she knows that if she begins to have this red and inflamed, sore, painful looking breast, that she does need to see a physician so she can get started on antibiotics. And we do want to teach proper breast care, so encouraging her to breastfeed on each side with each session, washing her hands before and after, using clean breastfeeding pads, making sure she's having adequate water and fluid intake, wearing supportive bras, decreasing stress, getting rest. So lots of different things incorporated with mastitis. Postpartum hemorrhage, I'm going to stop here and I will finish up with postpartum hemorrhage briefly on the last voiceover for this unit.